As Chief Operating Officer, we're responsible for our community to ensure we provide quality of care 24/7. So that means good care any day of the week, weekends, out of hours, which will be a challenge when we have different patient numbers, higher patient numbers on some days and less patient numbers on others. So this work has been really important for us to look at our ability to meet the fluctuating demands and ensure we have the capacity to meet those fluctuating demands. The other responsibility we have is to make sure that all of our staff working for us go home feeling like they have provided quality care and feeling confident about the ability for themselves to deliver that care. And again, our ability to respond effectively to fluctuating demand and having a capacity to adjust to meet that demand has been an important part of this project.
Hi, I'm Kay Gregory. During this short video, we're going to introduce you to a new way to manage care capacity and demand that will provide seamless patient care and streamline staff workloads. The findings of the 2005 Safe Staffing Healthy Workplace report identified the essential elements needed for providing quality nursing and midwifery care. It showed that to meet the needs of every patient, there must be the right number and staff mix to provide the right care at the right time. The CEO of the New Zealand Nurses Organisation, Jeff Annals, explains.
CCDM is a system of properly informed decision making that ensures that health services have the care capacity to make sure that every patient gets the care they need every time. CCDM isn't a theory or an aspirational goal. CCDM has been developed and tested by managers and midwives and nurses working together in real wards and departments, in real hospitals with real patients. CCDM works.
It really does work. In my ward, I had a set pattern of rostering that came to my ward, and I was limited to that no matter what the variance was. Safe staffing actually has changed that immensely from my ward. I have gone from 4 RNs per shift to 6 to 7 RNs, and it is totally as per variance. So it's about safety for the staff, safety for the patients.
I'd like to introduce you to Jane Lawless, who's the Director of the Safe Staffing Healthy Workplaces Unit. She's going to tell us a little more about how CCDM actually works.
Well, CCDM acknowledges that we don't provide care to beds, we provide care for patients. So CCDM achieves 3 things. The first is that we have the basic staffing design right every day. The second is that when there is a variation between what we need and what we have, that we can actually respond to that in a safe and effective way. The third is that we have the information that we need so that we can test those designs, so that over time and on the day we can see whether what we're doing is working or not. And for that we need good quality data.
And Jane, what's that good quality data made up of? What do the organisations need to know?
The organisations need to know what's going on. So it's probably best to ask that question of the people who are delivering that care, who know what's going on, and that's the nurses and midwives.
I need to know how my organisation actually decides what's the safe level of staffing, and also I need them to know from my point of view that the last thing I feel like doing at the end of a busy shift is filling out an incident form because of staffing levels, insufficient staffing levels, and feeling like it's not going to change anything.
We hear a lot about productivity and health workers needing to be more productive. As a union organiser with NZNO, I constantly see overloaded staff and a lack of resources. Nurses tell me that they're barely coping day to day with the workload. People spending half their day moving patients around or taking phone calls. I cannot see how that has been productive.
As a professional, it's really distressing not to be able to care for my patients the way I would like to because of the heavy workload.
We need our organisation to see what fantastic care we can provide when we have the right resources in place.
So we need to be able to show when we're getting into trouble and expect a quick response.
So some interesting comments coming from nurses there, Jane.
Yes, what they're describing is at the heart of the CCDM program. It's about having the resources and time to get the work done and really make that positive difference for patients. What they're also describing is how hard that can be to achieve. If we don't get the balance right between quality of patient care, a quality work environment for staff and making best use of the health resources, we can run into trouble.
So how does the program actually work?
Well, the unit comes in and works alongside the DHB and NZNO for 1 to 2 years, and we work together on putting those 3 interventions in place that I talked about earlier. So we'll start by looking at the basic staffing design, which is called mix and match. We work alongside a service to help them to identify what is the best possible number of hours, the best possible mix of staff, and the best possible roster or schedule to match with patient need.
We in this DHB are constantly asking ourselves how to ensure we provide quality patient care. And part of that discussion includes looking at our nursing numbers and ensuring that we have adequate staffing. We've had trend care in place for more than 5 years and felt we were doing well. It wasn't until we looked at mix and match and looked at the skill competencies and looked at the patient numbers and the matching of the nursing staff that we identify that in actual fact we had areas we could change and adjust and improve. And that's been of real benefit to us as an outcome of mix and match.
The next part of the process is variance response management. Mix and match will sort out your daily running of every day. It's a standard operating procedure. Variance response management is your plan B. You will get variation at times, and this is the plan that will address those issues that you may or may not get. And it's a pre-planned organisation strategy so you can deal with those moments.
So here we are in ED now with Marama. Marama, tell me how the VRM works in ED.
Basically the VRM works every day in Tauranga ED. Coordinators assess our status on a daily basis. In fact, they assess it 3 times a day at minimum, and they are looking at parameters that might throw us into a state of raised demand, and then with that signalling to the operations centre, we then activate our plan that sits behind that assessment tool, and we make appropriate responses depending on the level of VRM that we're in. So the VRM, since it's been implemented, which was in around 2009 here, we were using a colour code system for some long time, essentially helped us speak a common language in the hospital and helped the hospital to understand what was happening in the ED and helped the hospital to support the ED variant state. So it works incredibly well for us.
We have the hospital status at a glance screen behind us here, and along the bottom we have the variance response colours, and when these change we're ready to swing into action with strategies and responses that return us to as normal as possible, as quickly as possible. Of course, the ideal is that we don't get to that place in the first instance, and that our forecasting is accurate and capacity and demand match on a regular basis.
All right, Whakatani, are you online?
Yeah, really.
Hello.
This is the daily ops meeting. This is where it's all put into practice.
Alrighty, looking across at the Tauranga site today, we are pretty chock-a-block. We were slightly under what was forecast for Friday, but had a huge admission rate. Our ED is currently in yellow. I think the way things are feeling, we might have to partially reopen 3B. Keith has just popped ahead in before and she said that they are green.
So how is the CCDM strategy working overall?
Well, given that we started in the middle of 2009 with no program at all, I'd say it's an extraordinary achievement. But the main challenge we have is that uptake by the district health boards is still very patchy. So we have some who are well into the program and some who haven't started at all. The CCDM program supports NZNO and the DHBs to get to the place where change is possible, but we can't make the change. Where we have great engagement with the union and with the organisations, we see great things happen. This strategy will be successful when nurses and midwives, and most importantly patients, are enjoying the benefits of the CCDM program.
Well, let's ask Jeff Annals then what this means for nurses working in a DHB.
Staffing failures, staffing shortages, these are simply failures to plan. CCDM gives us the planning tools to ensure we've got staffing right. There's just no longer any excuses for staffing failures.
Nurses and midwives know about delivering care 24 hours a day, 7 days a week, and how health organisations work to deliver quality patient outcomes. Care capacity demand management is about unions and healthcare organisations working in partnership. It's about turning the knowing into doing. Using CCDM to create a positive workplace environment means honouring the commitments made in the NZNO DHB Mecca. We encourage you to become an active participant in this process. Contact your NZNO delegate, organiser or your professional nursing advisor to find out how to make CCDM work for you and your colleagues.